You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for April 9th, 2021. This week, COVID vaccines, hybrid AFib ablation, TAVR, and who gets to be named a doctor. So first up, COVID. Again, there's good news and bad news. The good news is that many areas of the U.S. are doing amazingly well. We're doing well here in Kentucky. And why is Texas doing so good? As it has had some of the least strict measures. Why is Michigan doing so poorly? It's hard to explain. I talked to a doctor at a big hospital in Michigan, and he says that admissions are up, but not at the same pressure as during the winter surge. Now, also good news in the U.S. is the vaccine rollouts. It was a rocky start for sure, but now millions are being vaccinated each day, and the data from Israel shows that getting the vulnerable people vaccinated associates strongly with declining hospitalization and deaths. Internationally, though, there's bad news. The high death toll in Brazil and rising cases in India are just so sad to see. Now, about COVID vaccines, I talked last week about the AstraZeneca vaccine and the clotting issues. But an update this week is that UK regulators have said that they will now offer an alternative vaccine to adults under age 30. They call the thrombotic events after the vaccine, quote, vanishingly rare, but sadly very serious adverse events. There's 2 points to make on this. First, the Winton Center for Risk and Evidence Communication at Cambridge published some very worthy decision support tools regarding the risk of vaccines versus the risk of ICU admissions from COVID-19, and I'll link to that paper. The short story is for medium exposure risk adults who are aged 20 to 29, so young people. The risks of ICU admission from COVID-19 in the UK was 2.2 per 100,000, and the risk of a serious clotting event from the AstraZeneca vaccine is 1.1 per 100,000. So to me, if I were under the age of 30, I could see no reason to take the vaccine. 2 bad outcomes are about the same incidence. So the UK regulator's decision seems wise. Now the second point to make, and the reason why this makes the podcast, is that those decision aids show that for high exposure adults or older adults, the risk of clotting after the vaccine is much lower than the risk of ICU admissions. And if patients were robots who simply chose the most favorable gamble, they would always take the vaccine. But doctors know that that's not how people decide. People feel risk as much as they calculate risk. And for some, they would feel more risk from the chance event from a vaccine. It's the same reason why some people decline anticoagulation for AFib. It's because they fear bleeding events more than stroke events, even though stroke is more common and more severe. Perhaps they've met someone or have a relative that had a severe bleed. Or perhaps they are a neurosurgeon. Okay, next topic. Hybrid ablation for atrial fibrillation. Well, I want to apologize to my listeners. A sort of big trial came and went in November of 2020 that got by me. Circulation EP published the Converge trial. This was an RCT comparing combined epicardial surgical ablation and endocardial ablation in one procedure to a standard endocardial ablation alone in patients with long-standing persistent AFib. Now, I mention this trial because patients have seen it advertised and have asked me about it. A search of YouTube returned oodles of videos from medical centers promoting the procedure as a major advance, and I've heard that some of my colleagues are trying it out. I've also seen the AtriaCure reps around, which means the staff are also asking about it, as in, hey Mandrola, are you going to do this new super cool procedure? So the combined surgical and catheter-based approach is called the convergent procedure. First, a surgeon makes a subxiphoid incision and places ablation lesions with a proprietary device made by AtriCure, the funders of the trial, onto the back wall of the left atrium for ablation of the back wall and around the pulmonary veins. Complete PV isolation via the surgical approach is not possible due to the pericardial reflection, so then, in the same procedure, an electrophysiologist goes into the left atrium in a typical way through the veins and finishes the PV isolation with a standard ablation catheter. Now, in the Converge trial rationale paper, published in June, after the trial results were first presented at HRS, the authors wrote that restoration of sinus rhythm in patients with longer-standing forms of AFib is an unmet need. A sidebar to my younger listeners. Whenever you hear proponents of new and aggressive technology say unmet need, be especially careful about critical appraisal. Now, the idea behind the convergent procedure is twofold. A, in patients with longer standing forms of persistent AFib, standard PVI, pulmonary vein isolation, may not be enough. Now, I would add that there is literally no RCT data to back that contention. People think it, but in fact, the seminal STAR-AF2 trial showed that more aggressive left atrial ablation strategies were no better than standard PVI in patients with persistent AFib. I'll link to that paper. It's in the New England Journal of Medicine. Now, the second idea behind a convergent is that posterior wall isolation via the surgical approach directs the ablative energy away from the esophagus, and that might help reduce esophageal injury, which is a good thing. Now, I would add here that there is no convincing RCT level data that adding posterior wall isolation improves outcomes over standard PV isolation. Now, in the Converge trial, 100 patients were randomized to the combined approach and 50 to the standard arm, and the primary efficacy endpoint, sadly, was a composite endpoint of just freedom from AFib, absent new or increased dosage of previously failed or intolerant class 1 to 3 antiarrhythmic drugs through 1 year. And I say sadly because it's a surrogate endpoint of AFib episodes, not clinical endpoints. The primary safety endpoint was major adverse events through 30 days. These patients were mean age 64, BMI 32 to 35, left atrial size 4.4, and about 4+ years out from their AFib diagnosis. The main result was that the primary efficacy endpoint was achieved in 68% of patients in the combined hybrid procedure versus 50% in the catheter ablation group. And, quote, without imputation for missing data as failures, the p-value was 0.04. A key secondary endpoint was AF burden. The authors chose 90% reduction in AF burden as their cutoff, and at 18 months, 74% of patients in the hybrid convergent group achieved this endpoint versus 55% of subjects in the catheter ablation group. Again, the p-value was about 0.04. Major adverse events occurred in 8 of the 102 patients in the combined arm: a stroke, a TIA, excessive bleeding, 3 late pericardial effusions, and 1 phrenic nerve injury versus 0 of these events in the standard ablation arm. The authors concluded, quote, the hybrid convergent procedure has superior effectiveness compared to catheter ablation for the treatment of persistent and long-standing persistent AFib. So my comments on this. First, let's talk about internal validity or trial conduct. There were baseline differences. 9% of patients in the combined group were on dofetilide versus only 2% in the standard arm. That's important because dofetilide may be the most effective drug in obese patients with long-standing persistent AFib. Another concern, the combined procedure had 22% females versus 47% in the standard arm. More females in the standard arm may bias the results against the standard arm because the preponderance of the evidence suggests females with AFib may fare worse after ablation. Now, the authors say this did not impact the primary endpoint because the subgroup analysis by gender showed a similar treatment effect, but they don't report the subgroups. There is no supplement attached to this paper. This imbalance may be a chance, but it also raises the possibility of selection bias. Now, another concern was the line in the reporting of the primary endpoint that read, quote, without imputation for missing data. I can't tell from the manuscript how much data was missing. There's no consort flow diagram, and as I said, there's no supplement. So I ask how much data was missing. Now a meta point. The Converge trial was sponsored and funded by AtriaCure. Numerous authors report compensation from the company. This is not nefarious. It is, however, notable. Now to the major issues, which are mostly external validity or generalizability issues. As I said, the primary endpoint is a surrogate endpoint of freedom from AFib. Converge did not have the power to test clinical endpoints, which are significant in patients with advanced forms of AFib. And even looking at the surrogate endpoint of freedom from AFib, the p-value barely met significance. A p-value of 0.036 or 0.04 calculates to a z-score of 1.8, not even 2 standard deviations away from no difference. Now, when I look at a p-value like that, it makes me think, how strong was this evidence? Now, one way to look at the strength of an evidence is to calculate a Bayes factor, which is akin to a likelihood ratio of a medical test. It's not fancy. Bayes factor is the probability of the data given no effect, or the null hypothesis, divided by the probability of the data given the alternate hypothesis of a true effect. And I'll link to a paper in the Annals of Internal Medicine that shows that. A super low Bayes factor or likelihood ratio is stronger evidence because a small number means the evidence is not consistent with the null hypothesis of no effect. The Bayes factor for the p-value of Converge calculates to 0.19, which is close to 1 on 5. And again, you can use online calculators for this. It's not fancy. Thus, there is nearly a 20% chance this data is consistent with the null hypothesis being true. Now, let's just say before this Converge trial even started, you were a little bit pessimistic. Let's say you look at all the prior data like STAR-AF2 and the fact that a skilled operator could accomplish a similar lesion set with a standard ablation catheter alone. You wouldn't need surgery. We can do this with a catheter. And therefore, you think the chance of no effect from this procedure would be more like 70-30 rather than 50-50. Now 70-30 is the same as 2.3. Now you can just use simple Bayes theorem you learned in medical school year 1. Bayes theorem just says prior belief times the likelihood ratio is equal to the posterior belief. Now recall that clinical trials are just like medical tests. They don't tell us what the answer is, they update our prior beliefs. Here you would multiply your prior belief of 70-30 odds or 2.3 times the Bayes factor or likelihood ratio of 0.19. And now you get a 44% chance of this data being consistent with a null. I don't want to make too much of the Bayes factor and statistics, but it does show that the data in Converge may be statistically significant, but are surely not strongly against the null. All right, now consider that patients in the Convergent arm had surgery requiring chest tubes and a total procedure time of 293 minutes versus 171 minutes with the endocardial procedure. On one of the promotional YouTube videos, I heard an author of the paper say the average length of stay was 3 days in the surgery arm. That versus 1 day for a usual standard endocardial ablation. Of course, there's no supplement, so I can't say what actually happened in the trial. And for that longer procedure time, open chest surgery, added expense, we get a barely significant difference in a surrogate endpoint. But none of that is the worst part. The worst part was 8% versus 0% major adverse events in the Convergent arm versus the standard arm. And remember that adverse events were what sunk the Convergent procedure when it was tried 10 years ago. In sum, this trial has statistically significant results, but for all of the reasons above, I would not recommend this procedure to patients. If ever there was a need to do a confirmatory trial, this would be a case in point. Next topic is transcatheter aortic valve replacement. 2 TAVR studies deserve mention. Now, 2 facts about the recent TAVR versus SAVR trials is that they enrolled patients with calcific AS and compared TAVR to traditional SAVR surgery. Jack has published an observational study looking at TAVR in patients with rheumatic AS. Now, TAVR in rheumatic heart disease is more challenging for 3 reasons. There's less annular calcification, which means there's less to anchor the deployed valve to, Rheumatic heart disease patients tend to have more AI, aortic insufficiency, and rheumatic heart disease tend to involve more valves, not just the aortic. Nonetheless, if TAVR could be shown to have similar outcomes, this may have huge impact in geographies where rheumatic heart disease is more prevalent. Now, the first author, Amgad Mentius, from the Cleveland Clinic and colleagues used the Medicare database to find rheumatic heart disease patients who had either procedure, TAVR, or SAVR. As these were non-randomized groups, they did the standard propensity matching, and as you would expect, surgical patients were younger and had fewer comorbid conditions. The authors made two major comparisons. Their first was TAVR versus SAVR in patients with rheumatic heart disease, and here they found that at 19 months, which is not very long follow-up, mortality was 11.2 per 100 patient years in the TAVR arm versus 7 per 100 patient years in the SAVR arm. The hazard ratio was 1.53, but it had confidence intervals ranging from 0.84, or 16% lower with TAVR, to 2.8, nearly threefold higher with TAVR. This was not statistically significant. The second question was TAVR in rheumatic heart disease versus TAVR in non-rheumatic heart disease. And here they had 89,000 patients without rheumatic heart disease who had TAVR and about 600 with rheumatic heart disease. And after adjustment, they found that the death rate was 15.2 versus 7.7 deaths per 100 patient years. And again, this was a non-significant difference. The authors concluded that compared with SAVR, TAVR could represent a viable and possibly durable option for patients with rheumatic aortic stenosis. And I love the modifiers could and possibly. Thank you, Dr. Mentius. The second paper is in the British Medical Journal Open Heart Journal, published a meta-analysis of 7 observational studies comparing TAVR to mini surgical aortic valve replacement, or mini SAVR. The first author is Dr. Ahmed Saeed from Ain Shams University in Cairo, along with colleagues in Egypt and Boston. They had the idea to see how TAVR stacks up to less invasive surgical aortic valve replacement. I learned from their introduction that a few years ago, less invasive aortic valve replacement was increasingly being done. I'm not sure what the percentage of mini SAVR is now in more recent years, but I talked to my surgical colleagues here and they say that it is done periodically. The potential advantages of minimally invasive aortic valve replacement over TAVR include the ability to directly observe the valve during the operation. You can remove annular calcifications, and there may be a lower incidence of paravalvular leakage. Now, sadly, none of the 7 included studies in this meta-analysis comparing the two techniques were trials. All were observational. But as a colleague once told me, you do the best with the data you have, not the data you wish for. Anyways, the main findings of this study are provocative. At 1 year, the risk ratio for TAVR versus minimally invasive SAVR was 1.93, and the confidence intervals go from 1.16 to 3.22. Said another way, TAVR was associated with a higher mortality that ranged from 16% higher to more than 3 times higher than minimally invasive surgical aortic valve replacement. A subgroup analysis of the 2 studies that used only transfemoral TAVR versus minimally invasive SAVR revealed a non-significant difference of hazard ratio of 1.71. Now, this could either be due to real difference or reduced power to detect a difference. Stroke and bleeding rates were not significantly different. And as for secondary outcomes, patients undergoing TAVR were more likely to experience paravalvular leakage, 14 times more likely to have paravalvular AI, but less likely to suffer acute kidney injury. We should be very careful about making causal conclusions from these observations. All of the studies included in this meta-analysis were likely biased from unmeasured confounding factors. For example, healthier patients may have gotten the minimally invasive surgical procedure. Nonetheless, the observation of higher mortality of TAVR versus minimally invasive SAVR, combined with the trends for better long-term performance of SAVR in the partner series, only adds to the caution I have regarding using TAVR in lower risk groups. Now, I highlight these 2 observational studies because I think both point to important areas where proper randomized clinical trials could be done. This is the only way to settle these questions. The final topic is doctor and medical degrees. Medscape ran a poll on who should get to be called a doctor. As many of you know, the Wall Street Journal ran an op-ed a few months ago saying Jill Biden shouldn't be called a doctor because she is not a medical doctor. I want to discuss this topic for a few reasons. One is that the first thing you have to realize is the business model of media. The currency of media now is attention. Making you mad is good for business. Nuance and balance is bad for business. So the first thing you should think about when an op-ed or a tweet or a biased news story makes you mad is that this is by design. In the same way you consider conflicts of interest in evaluating papers, I also urge you to be mindful of the business plan of media and platforms like Twitter. Resist the urge to be enraged. Now to the notion of who gets to be called a doctor. I strongly feel as anyone who wants to be called a doctor. 4 reasons. First, in my mind, a self-directed PhD would be far harder to finish than complying with the concrete set-out tasks in medical school. Yes, it was hard to memorize all that stuff, take all those tests, and work long hours, but it was set out for you. Do this, and you are a doctor. By the way, it doesn't mean you are a good doctor. In fact, superb test takers don't always make good clinicians. Now, contrast the well-laid-out plans of medical school to the open-ended tasks of a PhD. You get a PhD when you contribute enough to science. And I've done enough research to know that that is much harder than taking tests and memorizing differential diagnoses. Second point, while I love being a doctor, I've long gotten over the romance of it. It's a great job, but in general, we do well to get over ourselves. Sanctifying our MD is unbecoming. First, think about it. We don't control outcomes as much as we think. You come to realize from practicing over decades that people often heal and live well despite us, not because of us. Understanding how little control we have is very important for avoiding iatrogenesis. Now, don't mistake this for nihilism. I, of all people, think we should dedicate ourselves to our craft, but we should also recognize that, for instance, an APRN with a decade of experience in one field is surely as good or better than any newly minted MD. We should also realize that many of the therapies we consider excellent, Class 1 therapies, exert quite small effect sizes on individuals. Now, the other reason to get over the holiness of the MD is that when you get employed, you will learn that you can be off-boarded in 2 nanoseconds. You can have decades of service, and boom, you could be gone. Third point, getting hacked off about titles like provider is not worth the trouble. I used to care about this, but now I try to ignore it. Just revel in the notion that you are paid to help people. People who you help don't care what your title is. And fourth, finally, as a kid who loved basketball, one of the greatest childhood heroes I had was Dr. J, a legend who surely earned his doctoral status. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time to give us a rating, write us a review. It really helps others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.